right, good afternoon, everybody.
Good afternoon, Dr. Landry.
All right, so I got maybe two from this side of the room, so I'll try it again since everybody's sitting on the other side. Good afternoon, everybody.
Good afternoon, Dr. Landry.
Thank you. I know it's a cold, rainy day, so hopefully we can bring some energy into this lively discussion and welcome our guests who are here to speak with us about a very important topic. And I'm glad we're here at HMS recognizing the importance of our veterans, what they contribute to society, what they've done to serve us, and then also how we can continue to serve our veterans who are definitely a community in need of our respect and our care. So we are doing this under the auspices of our Equity and Social Justice Lecture Series. So we've been doing this for 4 academic years according to my notes here. And the purpose of these discussions are to provide both a historical context as well as the current and future state of health equity and social justice issues that are important to us, not only here at the medical school, but also in our community in Boston, and also taking a larger look at our region and our nation. Our events focus on 4 areas, as I mentioned already: history and context, culture and environment, health disparities, leadership skills and development. This year's ESJ series will tackle specific health issues that often impact disadvantaged and underserved patient populations. Our conversations and our speakers will address not just defining the disparity any longer. I'm pretty sure we've all recognized that the disparities are well defined, but actually look to interventions that can happen on a community, on a hospital, and on a policy level to address these inequities. We are thankful to have so many wonderful visitors and guests here. We have students and faculty and trainees from the Harvard schools, including HMS, Harvard T.H. Chan School of Public Health, as well as Harvard University. We have all of our hospitals represented, including Brigham, Boston Children's, Dana-Farber Cancer Institute, Beth Israel, and MGH. We have the Boston Public Health.
VA, Boston Healthcare System.
Oh, excuse me, and I apologize, the VA. We have our public health system here, including Boston Public Health Commission and the Center for Surgery and Public Health at Brigham and Women's Hospital. We have the medical library here, Chelsea Soldiers Home, Veterans Services of Northampton, as well as the University of Massachusetts Medical School. I just want to take a minute before we get started to acknowledge those who helped pull this together. So I want to say a special thank you to Teresa Carter, as well as Ying Wong for helping us to organize this, as well as the rest of the staff and faculty of the Office for Diversity, Inclusion, and Community Partnership. And I want to recognize our speakers who are here, including John Bradley, Jonathan Florance, Janet Fraser Hale, as well as Eric Goralnick, who's going to be our moderator for our session. And with that, I will invite Eric up to the podium. Dr. Goralnick is an emergency medicine physician and a Navy guy. That's the way he wanted me to introduce him. I'll give a little bit more to him because I feel it deserves it. He is assistant professor of emergency medicine at Brigham and Women's Hospital, and he's also the lead faculty for the Harvard Medical School Civilian Military Collaborative. He is a graduate of the U.S. Naval Academy. He also went to medical school at Tel Aviv University and completed his residency at Yale New Haven Hospital in emergency medicine. And he has been someone who's really helped to drive this effort overall at HMS and making sure that we think about our veterans in our conversations, but really someone who helped organize this event from pretty much day one. So I just want to say thank you, Eric, for your support in this. Thank you.
Can you hear me in the back? Great. Got a good infantry officer thumbs up there. That's good. So Alden, thank you so much. Thank you so much for coordinating this, and Ms. Ying Wang and Ms. Teresa Carter. I really appreciate all of the logistics and your leadership to set this up. It was really nice actually yesterday. I sent an email to Teresa, and her out of office reply was, "I'm respecting Veterans Day. My father served in the Navy, Chief Petty Officer, so thank you. This is a great tradition for you, and Alden, I know your father served, and I'm really thankful for your leadership on this." So I'm grateful for the turnout today to support our veterans, their health, and our civilian military community. Just a quick question, how many are faculty here at anywhere at HMS or otherwise? Staff? Students? Great, am I missing anybody? Okay, thank you. Thanks, Tina, for being here. So let's start with some numbers. 18.5 million. That was the total veteran population in this country in 2016 based on a national census. But this population has markedly decreased in recent years because World War II and Korean War veterans are dying. 8% of the nation's population are veterans. 1.6 million. 1.6 million are female veterans. The number of female veterans has grown significantly since the Gulf War, when significant numbers of women began enlisting in the military and subsequently have been able to serve in combat operations. 11.6%. 11.6% of these veterans were black veterans. Roughly 1 in 5 of those enlisted in the military today are black. 6.1% were Hispanic. 1.6% were Asian. 0.7% were American Indian or Alaska Natives. 0.2% were Native Hawaiian or other Pacific Islanders. 1.2% were some other race. 78% were non-Hispanic white. We are the military, and the military is us and represent us in many different ways. 6.7 million were Vietnam veterans. This is the census results in 2016. They comprise the largest living group of veterans. 5.5 million veterans served during the Gulf War era. That represents service from August 1990 to today. 1.1 million who are alive served in World War II. 2 million served in the Korean War, and 4.4 million served in peacetime only. 4 million of these veterans have disabilities. Approximately 4 million have a service-connected disability, which is defined as a disease or an injury, mental or physical, that was incurred or aggravated during active military service. Approximately 1.3 million of those 4 million veterans with disabilities have a rating of 70% or higher. 40,000. There are 40,000 homeless veterans in the United States. There were nearly 40,000 when a survey was done in one day in January of 2016. Over the course of a single night, they counted 40,000 homeless veterans. But there's hope. Unfortunately, veterans are overrepresented among our homeless in this country. They comprise about 8% of our homeless. However, this homeless population has decreased since 2010 because of several efforts within communities across the country. Homeless veterans tend to be male, 91%, single, 98%, live in a city, 76%, have a mental or physical disability, 54%, and black veterans in particular are substantially overrepresented. They comprise 39% of homeless veterans. They do comprise 11% of the total homeless population in this country. We're in a different time. Americans, on average, are far less likely to know a veteran. We're in a different time from World War II or Korea. They may know a friend or a family member that served as a veteran. And it's not just veterans, it's families of veterans who have also served, have supported veterans during deployments and other difficult times in and out of war and combat. The number of Americans who were in uniform peaked during the national mobilization of World War I and World War II, particularly the latter, when 16 million Americans served during World War II. As a proportion of the population, 14 times as many Americans served in World War II as did in any of the wars of the last decade. But we have an opportunity. And in particular, again, I'm thankful to Dr. Landry and his team here for bringing us together. We have an opportunity to bridge this civilian-military divide and form collaborations. It's long been said that it takes an average of 17 years for an idea to be adopted into medical practice. And the U.S. military, during the course of the last 15 years, with a research budget 1/20th the size of the National Institutes of Health, They implemented 25 major innovations over the course of those 20 years, in particular the last decade during the wars in Iraq and Afghanistan. In the latter years of Operation Enduring Freedom and Operation Iraqi Freedom, America's military health system achieved the highest rate of casualty survival in the history of warfare. Just 3 interventions: increased use of tourniquets, blood in the pre-hospital setting, and reducing pre-hospital transport times were associated with a 44% decrease in mortality on the battlefield. This equates to about 3,700 lives saved over the course of 16 years. The National Academies of Science and Engineering and Medicine in 2015 released a report that was focused on 0 preventable deaths due to trauma. The focus of that report was to translate the victories on the battlefield in medicine to the civilian setting, understanding the number 1 cause of death for those under 45 years of age in this country is trauma. An example for us in Boston that stands out is the Boston Marathon bombing. Approximately 30 tourniquets were applied in the pre-hospital setting by laypersons and EMS. Those patients were cared for and resuscitated by a combination of civilians and veterans, some reservists, some other veterans from various services in hospitals, 27 hospitals throughout Massachusetts and the greater Boston area that cared for 264 patients. And the care continues in rehabilitation centers that teamed with centers like Walter Reed, with active duty physicians teaming with civilian centers of excellence to provide the best care for amputees, and that care continues today. I'm particularly excited and proud of our HMS student veterans. A few years ago, John Florance, who's one of our speakers, we organized and started our civilian military collaborative at HMS that has been supported by Dean Ed Hunnard and Dean Saldana, who helped us really start to get focused on how we could bring this community together. Our aim has been to foster civilian-military collaboration, to improve patient care through visiting lectures, mentorship, and research. I'm particularly grateful that student leaders, including John, have stepped up to lead us. Zach and Bridget, who I don't see here today, Sam, and now Mitchell, who have spearheaded this initiative. We'd like to welcome you to join our efforts. You can go to civmil.hms.harvard.edu and get involved. So without further ado, I'd like to introduce our speakers. Each of our speakers will have approximately 15 minutes, and then that'll leave us plenty of time, at least half an hour, to field some questions. And we really want to hear from you and get your feedback and team together on how we can best care for our veterans. So first, I'd like to start off by introducing John Bradley. John Bradley serves as the Director for Mental Health and Chief of Psychiatry for the VA Boston Healthcare System. He was the gent that shouted out, "Go VA," right at the beginning. He's appointed as Associate Professor of Psychiatry at Harvard Medical School. Dr. Bradley joined the VA in 2011 after retiring from active duty in the United States Army, where he served as chair of the Department of Psychiatry at Walter Reed National Military Medical Center and clinical professor of psychiatry and vice chair at Uniformed Services University, which is essentially the medical school for the U.S. military that was started in the 70s. A native of Massachusetts, Dr. Bradley earned his BS in zoology at the University of Rhode Island and his MD from the Uniformed Services University of Health Sciences. He completed his residency in psychiatry at Letterman Army Medical Center in San Francisco, where he served as chief resident. His military career includes operational assignments for peacekeeping, stability and support operations, and combat operations in Operation Iraqi Freedom with the 528th Medical Detachment. He has served in academic appointments at UC San Francisco, Medical College of Georgia, USIS, and the Boston University School of Medicine. He's board certified in psychiatry. John Florance is currently completing his final year at Harvard Medical School. He previously served in the active duty Army Infantry and Special Forces from 2016 to 2014 before transferring to the reserve component to pursue medicine. He also deployed last year during medical school and took a little time off. In those roles, John has had multiple deployments as a combat leader to Iraq and Afghanistan. He currently resides in Brookline with his wife and 2 beautiful daughters. Janet Fraser Hale, PhD RN, is a professor of nursing and family medicine and community health and the Associate Dean for Interprofessional and Community Partnerships in the Graduate School of Nursing of the University of Massachusetts Medical School. As a critical care nurse and subsequently as a family nurse practitioner in the military, much of her focus has been with cardiac patients and efforts towards interprofessional and patient education to support wellness, health promotion, and disease prevention. Since joining academia, she has been involved with interprofessional education initiatives with medical and graduate nursing students working with medically underserved patients and populations in primary care and community settings to promote health and wellness. For over 20 years, she has co-led faculty working with both professions involved with community service learning initiatives, caring for some of the most vulnerable and diverse populations in Washington, D.C., Worcester, and Central Massachusetts. We're grateful you're here, Janet. Each speaker, again, is going to have about 15 minutes, and I'd like to turn it over to John. Thanks.
Great. Thank you very much for the introduction and the invitation to be here today with you all. Before we get started, how many in the audience are veterans or have a veteran in your household? Great. So what I'd like to do, one of my credentials that Eric didn't mention is I'm also a service-connected veteran, and I get all of my health care at VA Boston Healthcare System. So what I'd like to do is share an overview of what the VA does for us as a nation due to the generous contributions through your tax dollars in providing for really comprehensive clinical care, research and education for our nation's veterans. The nation has long struggled with how to care for our veterans. From the American Revolution on, we have tried to reconcile the healthcare needs of those who've served with the available resources that the nation can bring to bear. During the Revolutionary War, the only system that was in place, there was no healthcare system to speak of. MGH was not yet even a hospital. There were itinerant doctors, community practitioners around, and so no real healthcare system that could tend to the medical needs of our veterans, and the psychological needs had not yet even come close to being addressed. The closest our Revolutionary War ancestors came to getting acknowledgement is through the pension system that they would have to qualify for through impoverishment and disability that left them unable to work. Things started to evolve in the 19th century. When the Gettysburg battlefield was commemorated, Lincoln started to talk to us about how to care for one another and how to attend to the needs of the veterans. In his second inaugural address, he famously said, "To care for him who shall have borne the battle, and his widow and his orphan." This has become the motto of the VA. As apologetically gender specific as it remains, there's been a campaign within VA circles to broaden this to acknowledge our women veterans, transgender veterans, and others who are left out of this statement. But we want to be clear that this statement is intended to include every man, woman, or gender fluid veteran that is out there. We didn't really develop a Veterans Administration or any specific health care for veterans till the late 19th century, where some of the soldiers' homes locally started to be developed. The first of which was up in Togus, Maine, which has become the VA Medical Center up there. But since World War I, and we're in the position now of celebrating the centenary of the end of World War I. In fact, I was in New York City over the weekend commemorating the centenary of the return of the World War I doughboys to be welcomed home and acknowledged by the nation as having made a profound sacrifice on foreign soil in service to the country. And those doughboys came back with profound, debilitating physical and emotional wounds. And the nation didn't really have a way to understand that. Psychiatry was in its infancy, and the concepts of shell shock were becoming well known to the country. And so people started to put their heads together and think about how we might attend to the needs of those veterans, and various different commissions were put together. It was the nascency of the mental hygiene movement developed by Colonel Thomas Salmon, who was the first psychiatrist to serve as a psychiatrist in the United States Army, and developed the echelons of medical care and the evacuation system and the treatment principles for combat stress control casualties that still stand today. He described the need for treating psychiatric casualties using what he called the PIES principle, standing for proximity, immediacy, expectancy, and simplicity. Proximity to their wound and their unit, immediacy, as quick to the trauma as possible, expectancy, with the expectancy of return to duty, and simplicity, 3 hots and a cot, restorative care, and return to the battlefield. He demonstrated extraordinary return to duty rates and minimization of psychiatric casualties. And so that laid the groundwork for some of the mental hygiene movement that still has its tentacles in community mental health centers and state hospital system. It wasn't until 1930 that the VA, then the Department of the Veterans Administration, was developed as an amalgamation of a number of different organizations, and really started to attend to caring for the physical and emotional sequelae of combat. In 1945, it was then directed by General Omar Bradley, which was significant because he was known as the soldier's general. And so he really took pains to whip this administration into a well-functioning hospital and benefits system. And it was later elevated to a cabinet-level position by President Reagan. So what does the VA do for us? Eric talked about the large number of veterans. We ballparked that up a little bit to 20 million veterans living in the United States. And yes, their numbers are decreasing. But this is your veterans' comprehensive, interdisciplinary, integrated healthcare system across the nation. We care for veterans whether or not you live near a VA. In the 21st century, now we provide telemedicine support. If you live in East Moose Breath, Idaho, we can reach you and provide VA care to you as a veteran. Too few veterans actually avail of the services that we have. Only about 9 million of the 20 million are reliant on VA for their health care. Like I mentioned, I receive all of my health care at the VA, and it is second to none. The VA often has a reputation of an also-ran type of healthcare system, but it is one of the Harvard affiliates. It is staffed by you and our colleagues who are all very well trained and provide exquisite care for the care of the veteran. We are one of the only healthcare systems on the planet that has full parity for mental health care. That's an issue that we are really advocating for across the nation, that mental health care is primary care, and no place does it better than the VA. At VA Boston, we provide every level of care, from acute inpatient psychiatric treatment through early recovery and rehabilitation care to general and subspecialty outpatient care and homelessness outreach. We house 1,000 veterans every year from the Boston area, really trying to chip away at the national scourge that is homelessness. VA is also the educational platform for most of the United States healthcare practitioners. 75% of all physicians and 80% of all healthcare practitioners do some time in their training in the walls of a VA medical center. So we are you, and you are us. With this partnership with our academic affiliates, it allows us to be successful in providing, for serving the underserved, our nation's young men and women who have donned the uniform and written a check in service to the nation for the last full measure if needed. We're also an extraordinary research consortium. Particularly at VA Boston, we've got the largest research portfolio of any VA in the nation, and that includes NIH funding, DoD funding, and the VA has its own grant system, which is one of the little-known things that makes VA a great place to work in giving us, who are interested in research, a new funding stream when the NIH dollars seem to be more and more difficult to achieve. And we have various centers of excellence across the country that focus on the issues that are important to military veterans, particularly a number of research consortia that have to do with suicide prevention, post-traumatic stress disorder, and the so-called signature wounds of war of the current day. So VA is your national resource. It is the way that the American public, the nation at large, makes good on the promise to care for him who shall have borne the battle, and his widow, and his orphan. We're not only a healthcare system, but also a social safety net to try and reverse some of those social determinants of health that military veterans are dealing with. GI Bill is a veteran benefit. Housing assistance, VA loans, and the whole bit. And I count myself very lucky to be a recipient of all of those things. My daughter is now at university on my GI Bill. And so my family thanks you for that. We fill an important niche in the American consciousness to care for our veterans. Because when Rand Corporation, in fact, did a survey of New York practitioners across the entire state of New York and found that most didn't feel like they had the military competencies to care for veterans and their family. And so part of this mission, speaking here today, collaborating with our academic affiliates, is to help increase awareness about medical competencies that are needed to care for our nation's veterans. And so with that, I thank you for your attention. We'd be happy to answer any questions and continue this discussion at the panel. Thank you very much.
So, my name is John Florance. I'm a fourth-year medical student. Really honored to be up here as a part of this distinguished panel. I'm just starting my medical career, and because of that, my medical experiences are pretty limited. So really, I'm going to lean heavily on my Army experiences to hopefully add some value to this talk. I first enlisted when I was 17 years old as a private in the infantry of the reserve component. Shortly after, I actually found my way to West Point and then back into the infantry as a platoon leader, and then eventually in the special forces as detachment commander. I've spent time leading troops overseas in Iraq, Afghanistan, and Libya, along with shorter trips to Cameroon, the Balkans, Korea. And as Dr. Goralnick mentioned, the most recent one was this past winter when I took a 4-month leave of absence to join a former special operations unit in Afghanistan. So I'm hoping with those experiences complemented by my nascent medical experience that maybe I can convey a little bit about veterans in a way that empowers medical practitioners. And I plan to do that by identifying 3 larger themes, if I have time, and I don't babble too much. And I think those are kind of universal to the services, but undoubtedly there'll be a little bit of bias as I just talk about my experiences on the GWAT, or Global War on Terror, and as a veteran who served exclusively in the combat arms. So grain of salt, just my opinions. So this picture here is the troop levels in Iraq and Afghanistan. While the Global War on Terror is still ongoing, I think when we say the GWAT, we talk about the bulk of it being shown here when we had hundreds of thousands of troops deployed to Iraq and Afghanistan. And those numbers have come down quite a lot. Right now in Afghanistan we have about 10,000 troops, in Iraq about 500 in places like Syria. But looking at this chart, I wanted to focus on that Iraq troop surge in 2007-2008, because that's when I first deployed with the 101st Infantry Division as a platoon leader for a 15-month combat tour. And that surge was actually a pretty difficult time for our military. Traditionally the military operates in what we call a red, amber, green cycle. So your green cycle, about 1/3 of your time is when you'd be thought to be overseas deployed. And then the other 2/3 of your time you might not be home, but you're probably not overseas at least. For the red cycle, you're doing a little bit of rest refit, but you're also doing individual schooling. For me, that was coming out of Ranger School, Airborne School before joining the unit. Then you check your amber cycle, which is your collective training, where you kind of come together as a unit and start kind of working together. So you might spend a week out in the field doing live fire ranges, maneuvering as an element, as a squad or platoon, or going to the shoot house and having people observe you and critique you. And then you'll also do a pre-deployment kind of train up. So went down to Fort Polk, Louisiana for a month to work as an entire battalion to try to get our processes down and work together before actually going overseas. So all that said together, I guess I'm saying doctrinally, best case scenario, I think soldiers would spend maybe 1/3 of their time at home. Maybe 1 out of 3 nights they'd be sleeping next to their spouse, seeing their kids at night, which is already a pretty heavy toll. And so when you have this surge, you're talking about breaking that cycle. You're saying, hey, we actually need more troops. We got to take them from somewhere. And so for the unit that I joined, that meant coming back from a 15-month tour in Iraq, almost as soon as you come back, being told, hey, get ready, we're spinning up, we're going again at the end of the year. So over the course of 40 months, being gone for 30 of them, and when you're talking about these guys in their young 20s with families, that's a tough pill to swallow. I think being told you're miss if you have a 2 or 3-year-old at home, you might know him for a few months, and you're just gonna be back out. So I guess what I'd like to kind of share from that is just that despite that load and that burden and being told to go again and again, despite being stop-lossed in some cases, about 10% of my platoon actually going outside of their contract time to continue serving because the needs of the Army say, hey, I know you signed up for 3 years, but fine print, we need you for longer, so you're coming up with us for this 15 months. Despite all of that, just really honored.
Thank you.
Yeah, thanks.
Thank you.
Yeah, right. Yeah. So just honored to be a part of that kind of organization. And so that's kind of why I put mission first at the top here as like a theme for the military. I think as a basis, as a mentality of soldiers, a culture that sometimes terrible things just kind of happen, and instead of complaining about it, you can just, instead of complaining, you can just Ranger up and Charlie Mike, so continue the mission, complete the mission. And so I think that's why I think, for the most part, from what I hear and when I talk about practitioners, I think people like caring for veterans because, they're people that for the most part, can see some pretty terrible things and in the end feel okay about it. Just in my own experiences, working at a VA, getting a sub-I experience there, and someone coming in with just terrible infections on multiple fingers, multiple hands, and a surgeon comes up and solemnly says, we need to talk about amputation, and this guy just doesn't blink an eye. It's just like, what do you have to do, doc? Let's get it done. So I think that's kind of the mentality that soldiers have, and I think it's like a real credit to them, and how we engage with them as providers. And personally, I think, if I had to think about it a little bit, I think there's like some bit of fatalism that kind of goes along with that mission accomplishment, kind of mission first mentality. Sometimes things just happen. Sometimes you draw the short straw, and sometimes you don't. And overall, I think for those of us that are living relatively unscathed, that they're spending enough time in a combat zone, I just feel lucky. I have a great family, 2 amazing daughters here at the world's best medical school. I look at where I am now versus where I was 10 years ago, and it's just, it's pretty amazing. And so on the positive side, I think this fatalism is kind of powerful and talks about, every day's a gift. And because besides fate, who's to say that the improvised explosive device that hit the truck in front of me didn't hit me, or, the bullet that flies by your head doesn't come a little bit over. So, but I would say as practitioners, I caution you that some of the same fatalism can kind of have a negative side. I call it survivor's guilt. But sometimes, it's hard to make sense of why you ultimately made it through and others didn't. And so, overall though, I think, mission first and survivor mentality makes veterans just a uniquely resilient population. So, oh, that was the easy part. It's only getting worse. So we talk about the all-volunteer force. 1973 is the year that we moved to an all-volunteer force. We eliminated the draft. And there's a lot of social commentary around that as an issue for a country, but I'm not here to talk about that. I just want to give you one example of why someone might choose to serve, to answer the call. For some people it might be money or glory or adventure, but I'll talk about my own example at least. And to address what that means a little bit, I'll talk about the second part, which is the oath of office for an officer. There's a slightly different one for enlistment, but only so much room on a slide, so I'll put that one up. So, I joined because of the values I saw in my family. My grandfather served in World War II in Korea. My father served in Vietnam and then much later in Iraq. I grew up attending Memorial Day and Veterans Day ceremonies every year. I remember handling my grandfather's war ribbons and seeing my dad march in the 4th of July parade with the VFW. But more than those experiences, I think there's just an underlying framework in our family of the Army values, or what I've come to know as the Army values. Just things like you should do your duty. You should be a man of honor, integrity, personal courage. And, perhaps a combination of all that, the national anthem always made me a little misty-eyed, which is probably a good indicator of a natural proclivity for a military service. So at the very least, I think it helps assimilate you into the culture. And it was actually reminded on my way home this past winter in April. I was flying home and I had a couple days in Qatar waiting for my flight out in a small, U.S. operated military post there. So there's like a movie theater. It's like, I might as well catch a movie. And you go into the movie theater and you kind of forgot that at military movie theaters they play the national anthem before you watch the movie, which is just a very unique part of the culture. So you're sitting there eating your popcorn, you're watching some previews, all of a sudden everyone stands up, and do it, and it's back down. So, and I think it just reminded me how much these symbols of patriotism can surround you and really affect your decisions ultimately. So, while my father never encouraged us in the military, my older brother enlisted in the reserve component at 17 to help pay for college, and I followed suit. And then shortly after, actually 9/11 happened, and a swelling of patriotism, I decided to go to West Point. And so what that means to me, everyone's experience is deeply personal, but I'd like to point to 2 parts of that oath that always stood out to me and try to relate it to my experience. Support and defend the Constitution. You're not pledging allegiance to any person or any organization. It's to a document, and some might say a living document, and that's kind of tough. It's not as simple as following orders that people might think, you're in the Army, you just follow orders. It takes thought and reflection, maybe a little soul searching. And while you can look to others for advice and mentorship, you're ultimately on the line for your decisions. And as a Special Forces Commander in Libya, it was just very real because it was just me and my team in a country that was literally falling apart around us. My boss was on a completely different continent. We'd be driving downtown Tripoli in unmarked Toyotas wearing low visibility plate carriers under civilian garb, assault rifles at our feet. machine guns in the back. We'd have backpacks just full of, grenades and ammunition and stacks of cash. And more than one time, I just caught myself thinking, am I doing the best to balance things like the welfare of my team, the safety of my team, while trying to accomplish the mission? And I think we had just a number of close calls that really stressed me as a leader and coming back to, if I'm truly doing what I'm supposed to do. And so while everyone's military service is a little bit different, I think everyone can say that the military does a good job of putting you outside of your comfort zone and having those kinds of experiences where you're really searching. And now this was the last part, just to well and faithfully discharge your duties. To me, that was just like a crushing obligation. Am I doing everything within my power to accomplish the duties of my office? Could I do more? I don't think I have to lecture a room of medical professionals, but you really question yourself when you're faced with losing someone. And then when you face that loss directly, after we lost a couple guys, the first couple of guys we lost in my first deployment, I was personally tasked to go through and inventory their stuff. And some of it's small things like personal effects that you put into a container, lock up, send home. And then, you see other times, caskets draped and American flags being loaded onto a cargo hold of a flight. Or hearing the names of the final roll call at their funeral services. And for those who's haven't been to a military funeral, the final roll call, the first sergeant, who's the senior non-commissioned officer, just like top, come up to the top in front of everyone, stand next to the soldier cross, assault rifle into the boots, dog tags, and we'll call out a roll call. I thought I could do this a little bit better, but I don't know if I can.
You're doing it.
We'll call out names. Sergeant Brian Andre, here first sergeant. Second Lieutenant Jonathan Florance, here first sergeant. Staff Sergeant Jonathan Martin. Silence. So what does that mean for taking care of veterans? I would just say, honestly, we're all a little weird. We have our own very unique insular culture that is, I'd say, highly emotionally charged, if that wasn't apparent. And then also as volunteers, I'd say we're infinitely proud of that service, that we chose to serve, that we volunteered to leave our families to fight. So when you hear comments, these guys in their silly veteran hats and, were they talking about something they did 40 years ago, or conversely, you hear a veteran patient yelling obscenities about someone kneeling during the national anthem, or desecrating the flag, or they're lamenting about their Second Amendment rights. Obviously all that can be very hard, but, I just challenge you to, take a second and, try to make that connection. Some small things like thank you for your service, but I would say like when did you serve, where were you stationed, what was your MOS? And I'm out of time. I just wanted to bring up a few things that can also kind of help you connect. I'm a big believer in these kind of symbols. I wasn't when I was younger, but they've come to mean a lot more to me now. So top left, that's Screaming Eagles, 101st Infantry Division. That's the division I was part of. It's featured in HBO's series, Band of Brothers. Bottom left, you can see the 82nd Airborne, which is probably an equally very well-known, popular infantry division. Those are the two you'll probably see the most. Airborne wings. POWMI flag, just people who are lost, never returned from war. Every dining facility in the military has a table set for one, waiting for their eventual return. You have the campaign ribbons of Afghanistan, Iraq, and Vietnam. Shout out to Special Forces. Bottom left, that gold one, it's like it's a Navy one. I probably need some help. It's like a fork. I think they're like a dining unit or something. Navy SEALs, I think. Iron Mike at Home of the Infantry, Fort Benning, Georgia. And then this bottom right's another really big monument for the Navy. I don't know it. I think Dr. Goralnick can explain why there's these people climbing a Greece monument. I'm not sure, but I actually think this one kind of looks like Kim. So you can probably tell. And that's it. So thank you. Thanks. Sorry.
Guess I'll have to hold it. Thank you. I'm humbled to stand before you today. I wanted to be first. Now I know why. I want to thank my colleagues for the sacrifices you have made for our country. I loved being in the Army. I didn't have to go in. I didn't have to stay in. But I grew up in a military family. I grew up at West Point, New York. My dad went to West Point. My brother went to West Point. My husband went to West Point, my former spouse, and the man I currently date went to West Point. There's a certain culture about the military. It kind of draws you together. And there are a lot of good and also negative commonalities that you share. So I wanted to share with you what I've been trying to do predominantly at UMass Medical School, along with some of our students who are veterans. Over the years, our momentum has grown relatively significantly, I believe. So I just want to share a little bit about that with you. I also had the honor to work with the team to prepare a report for a subcommittee of the Massachusetts legislature. And they wanted us to predict what the services that the veterans would be needing in the next 30 to 50 years in Massachusetts. And I'm happy to tell you that that resulted in a bill that actually funded the Chelsea Soldiers Home to partner with the VA. And I don't know if you've ever seen the facility. It's an old facility. It hasn't been well cared for, but I can tell you that the care that the veterans there receive is incredible, and the love of the staff who work there. So I'm very happy to say that they are in the process of building a new community living center, which is the state-of-the-art facility now for our aging and infirm veterans. So one of the things that we are trying to encourage folks to do is to ask the question, did you or a family member or loved one ever serve in the military? We specifically do not want them to ask, are you a veteran? Because there are plenty of people who have served who are not considered veterans. I think the most incredible thing to me is that if you're in the state of Massachusetts and you've served in the National Guard, unless you deployed, even though you served 20 or 30 years, you're not considered a veteran. And I know they're working very hard to change that because nationally you are recognized. So there are also many people who aren't proud of what they had to do in the military. They suffer from moral injury. I think our Vietnam veterans in particular are the most, they've been the least valued, and I entered the military during the Vietnam War. I wanted to take care of soldiers. That was what prompted me to join the military. Unfortunately, I never went to Vietnam because I was sent to Germany. So I was very grateful when I had a chance to deploy for the first Gulf War. I felt like I had a chance to sort of pay back what I hadn't done earlier. But I think the Vietnam veterans are also some of the ones that are most likely to be homeless, as John has shared with you earlier. Some of them want to be homeless. Some of them do not want to be housed, and that's fine. Some of them need permanent housing. They can survive, they can go to work, but they need the comfort to be able to come back to a certain place where they're housed amongst people who have had and share similar experiences. So I don't want to spend any more time, but it's really a very powerful area to pursue when you actually talk with some of the homeless folks. This picture depicts some of the things that we're going to mention really quickly. You have the invisible wounds of war. You have military sexual trauma. As John's first, Dr. Bradley's first slide showed, war is not good for your health. You have some, of the soldiers come home, and then some do not make it home. Women are a large portion of the military these days, and so we will need to make sure that we're caring for them. The VA is doing an amazing job of expanding their services for women. Combat creates its own concerns and issues along with injuries. And the top right one is the most significant for what I have to say, and that's in Massachusetts, your veterans are going to often be invisible. One, because they don't volunteer to tell you that they were veterans, and two, the majority of the veterans in Massachusetts of the younger generations are National Guard or reservists. So they're not entitled to the same things that you get when you've been active duty. They don't come from a main base where you have the support services that you need. And so I want you to remember that your patients are going to look like everybody else. And if you don't ask them, they're not going to tell you. So I mentioned this a bit. Why do we ask? Again, they won't reveal it usually. And most are unaware of the health risks that they face related to their military service. In my next slide, I'll just begin to cover some of those. And then they're also reluctant to disclose because of the media coverage of veteran aggression, violence, homicides, and suicides, and hopefully the next slide will help to explain a little bit about that. And then the Vietnam era, as I mentioned, they were drafted. Many did not support the war, and they came home to a very unwelcoming nation. So they suffer a lot. So the health risks are faced by military servicemen and women are many. We all are aware of the battlefield injuries, the trauma, the burns, the amputations, the traumatic brain injuries, which is the signature wound of the current wars. Exposures to toxic substances, the burn pits, the oil wells from the first Gulf War, which the bottom left photo is. That was noontime on our compound in Iraq, just below Iraq. And that was from the inversion. There was an air inversion, and the burning oil wells created total darkness, and we were all covered with oil. And that can't be good for your health. The one is a picture of the burn pits, and the other is an accident with possible head injuries. So I wanted to just mention, if somebody served in the military, they have a 60% greater risk of getting ALS, or Lou Gehrig's disease. And if your patient has ALS and they're a veteran and they've never mentioned it or told anybody about it, you could be the first person to connect them to the VA services. They also would be due compensation, and their homes would be totally renovated to support them. Veterans have a higher rate of hepatitis C, particularly the Vietnam era veterans. They don't know the reason why, but they do. One of the supposed possible causes was when we went in and during the Vietnam War, they immunized us with these guns, and they would just line you up and go right down the line using the gun, and that's how you were immunized. They don't, again, we don't know if that's the cause. Soldiers carry a minimum of 60 pounds. I'll bet John Florance probably carried upwards of 130 to 150. The Special Forces folks are special people, and that's why they're called special forces. And they carry a lot. Moral injury, that's only beginning now to be studied, but people are now looking into that. And then hearing loss, if you have a patient who's a veteran who has a hearing loss, if they go to the VA, they will get state-of-the-art hearing aids. I think they replace them every 2 years. Please correct me if I lie. And it's an incredible service. Substance abuse, homelessness, suicide, domestic and child abuse, these are all the things that your veteran patients and their family members are at risk for. I wanted to mention a bit about Agent Orange. Agent Orange was the herbicide that they used during Vietnam to defoliate all of the ground so that they could identify the enemy better. And there are many diseases that are associated with Agent Orange. There's also a number of diseases now associated with the Gulf War, and it took us almost 30 to 50 years to discover what the diseases associated with Agent Orange are. We're doing a better job now of identifying the presumptive diseases associated with the current war and with the Gulf War. So the research is pretty good. The VA doesn't just make these decisions that something is presumptive. They have these reports where they collect the evidence from the previous 2 years, and then they try to look at it and see if they really can determine a presumptive association. I know one of the ones that hasn't been supported yet is glioblastoma, but among my colleagues, they see a number of people from the Vietnam War with glioblastomas, so I know that the VA is looking into that, or the DOD, whoever's doing that particular research. The diseases that are associated with these exposures many of them are very serious cancers, neurological disorders, type 2 diabetes, prostate cancer, lung cancer. They're all can be associated with Agent Orange. So your Vietnam veterans have the option, if they're not connected with the VA, for many, many supports as well as compensation for their time. In the few minutes that I have left, I just wanted to tell you what we're doing at UMass Medical School. We have a 2-week interstitial, which is really an interclerkship. They decided to change the name. And it is an immersion into a community of medically underserved or vulnerable population. And so one of the 30 choices that the medical students and the nursing students have is the Veterans Health and Military Interstitial. And during the 2 weeks, we visit many associations. We go to home base. We have many speakers that come in and talk to them, and it really helps them to understand the importance of asking the question. We also have a one-day interclerkship. Sorry, the first was a clerkship. This is an interclerkship that's required of all medical students and all graduate nursing students, where we give them the condensed version of the importance of asking the question, knowing what health hazards the veteran may face, and also that they know enough and how to connect them with veteran services. So I think my time is up. I just want to thank you again for this honor, and I look forward to any questions that you might have. Whoops. Right.
So first and foremost, I want to thank all of our speakers. And we're going to transition to some questions from the audience. I think what we heard were a lot of different perspectives, a diverse group of perspectives. We first heard from Colonel Bradley describing his experiences, in particular a masterful review of the VA services for all of us as America's healthcare system. We heard some open, honest, personal reflections from Jonathan, which we're all grateful for. And from Janet, we heard some really interesting particularly facts around health risks that face our service members, that are unique to our service members, and the leadership of the program she's running at UMass around exposure to veterans and their health risks for our healthcare providers. So I'll take the liberty of asking the first question. We've heard from all of you on different perspectives, and we've heard and seen from people here in the audience. They represent students and faculty and administrators and various groups from across Harvard Medical School and the community here. If they want to sort of leave the room here, how can they be involved? How can they take what you've shared with us today and help our veterans? Are there ways that they can get engaged?
I think one of the first things they can do is recognize the veterans in your lives and under your care. As Janet pointed out, ask the question, have you or a loved one served in the military? The VA has done a great job of kind of collecting a number of resources that are available, and we've got one of our outreach liaisons, Colonel Dave Henke, here with a lot of literature, which is an overview of some of the resources that veterans are eligible for, as well as things that you can be doing. So I would encourage everybody to visit the booth outside and load up with some swag.
Dr. Hale?
Sure. I failed to show you my last slide because I wanted to be on time. But the last slide was a way that you can thank veterans. One of them was to say, instead of thank you for your service, which some, not all, but some feel that that's trite and it's just kind of what everybody sort of, it's kind of cool these days to do that. But now you can see that you can say it in a bit more meaningful way. In particular, the middle one, I mean, if you are engaging with a patient and you find out that they're a veteran and you start to ask them, again, as mentioned before, what branch did they serve in and what era, because that's going to help you in terms of making diagnoses. And then at the end, if you thank them for helping you to help other future patients. And if we had an hour, I could tell you all sorts of stories from my medical and nursing students when they have actually asked the question of people in nursing homes, dying patients who it turns out are a Vietnam veteran who's been fighting demons their entire life, and they finally have a chance to kind of unload and maybe, we hope, die a little more at peace. Again, these just give you some other options in thanking them. And if you know somebody who's a veteran and they've never registered with the VA, whether they think they have, any health care issues at all, it's really important for them to register, and again, correct me if I'm wrong, to register. One is it helps the VA in terms of their numbers of people who are registered. And they also, if they have any service-connected disability, then, or if it's determined that they do, that portion of their health care will be covered by the VA. And once they're 65% disabled or affected by their military service, then they can receive all of their services through the military, including a pension or a compensation of some type. So I think to help them, if they would go and register, they can just go to their local CBOC, community-based outpatient clinic, and then bring in their DD-214 and be seen.
Discharge paperwork.
Oh, sorry, yeah. Also, I know that there is some concern because a number of veterans are not considered, they didn't have an honorable discharge. Vet centers will help them, and the vet centers will often help them to connect to the VA to be reevaluated, because particularly in the last 10 years, we've lost a number of people from behavior that was not becoming of a soldier or a sailor or an airman. And now they're realizing that folks who have experienced TBI, you don't even have to have felt the impact of the explosion. And you may think that you're fine, but it can affect your brain and there's a honeycomb pattern in particular that looks different from TBI of a motor vehicle accident or, contact sports like football. And it affects the executive function of the brain, which can impact on some of their behaviors. And so the VA is now looking or the DOD and changing their discharges from dishonorable to honorable.
Just briefly. I would say, just the same way you would engage with any group, you just invest a little bit of time. I think it's easier on the military side because we actually have 2 holidays dedicated towards either veterans or, people who have given their lives in service to the country. So, just going out to, the municipal ceremonies are a great way. Yesterday was a Brookline ceremony. I love going to those. I wanted to show solidarity and be there for my brothers and sisters, but also because I have 2 young girls and, I feel like it's a great way to pass on values that I, appreciate, and, I want them to be Green Berets one day, so.
Great, so we'll open it up to questions.
Happy Veterans Day, and thank you all. This was absolutely marvelous. My name is Sadie Alicio. I'm an internist, and I've been practicing primary care in the VA system for about 6 years. Just moved to Boston, and I'm noticing a couple trends in all of the new patients I'm seeing. There are many individuals in their 20s and 30s who are just getting established at the VA, particularly requesting mental health services, which is wonderful, because I know how robust that is at the VA. The second group is people in their 60s to 70s who are being convinced finally by their buddies to explore this service. And there are very complex reasons why veterans who served in Vietnam hadn't accessed VA healthcare maybe until now. My question is, what are the ways in which veterans are encouraged to enroll in healthcare? How are they informed about VA services? How are they recruited to join, both for individuals who are closer to their military service and for individuals who served many years ago?
I'll take a stab at that, and thank you for serving in the VA and taking care of our veterans with us. Most veterans who are not transitioning directly from military service, and for those who are, there's a very tight linkage between active duty and veterans health care, where you get enrolled, you identify what VA you're going to end up residing near, and you can get a jump start on your disability evaluation to get your service connectedness. But for those veterans who've been out of the system for a while, and you mentioned the complexities around some of those experiences, many are cynical about what the government might do to or for them, and have some great apprehension around accessing the benefits that they've earned and that they've deserved. It's really by buddies. The military functions on camaraderie, on looking out for the person to your left and your right, looking out for one another. And so it's those buddies, it's those family members who, see a flyer or an ad on TV or sitting on the bus, poster, in public transportation that say, VA, I wonder if Uncle Joe is eligible for that. And they grab him by the arm, and Uncle Joe always says, oh no, there are 10 guys worse off than I am who deserve to be at the front of the line. My dad is one of those Uncle Joes. But they deserve these benefits, and it's incumbent upon us to be the chorus in support of those families who are, worried about Uncle Joe, or say, hey, you really ought to get what is your due. Because these aren't entitled. These aren't, in the negative connotation of entitlement. These are earned benefits, right? And we want everybody to get aligned around ensuring that the veteran gets the access to the health care, to the financial support, the pensions that are, we're all paying for those. And we don't want them to be sitting in coffers in Washington, D.C. We want them to be distributed to our nation's men and women. So it's the network, and we are part of that network to encourage That's why when we ask the question, have you or a loved one served in the military? Let's think about, well, have they gotten plugged in with the VA to get the benefits that they've earned and deserved?
Again, thank you for your presentations. One of the things a few years ago, I was working with a group of folks who were looking at how to incorporate this question about prior military service into their EMR. And I don't know if there's a lot of EMRs that actually have that as one of their mandatory questions as part of registration. A, should we be doing this? And B, what are the pros and cons of potentially adding a question about military service into an electronic medical record?
I'm happy to address that. So we at UMass, we just incorporated, or we just took, I don't know how to, it's tough. Anyway, Epic just came to our hospital. We've suffered through it for, a while. I think most of your hospitals have Epic and you've been using them. So I actually have a medical student who wants to work with the team, the EPIC team, to integrate the questions about the veteran. And EPIC actually has a module, a whole chapter that's already made up for that. But it's in the queue, they tell us. But it's a line right there with all the other social determinants of health that we struggle to get into the EMRs. And I don't think it's because people don't think they're important and don't want to deal with them. It's the fact that once you ask the question and they say yes, then people feel helpless in terms of, okay, well, now what do I do? So I know in terms of asking the veteran questions, that's kind of what we're trying to do, is to give people, more support. And then but for all the social determinants of health, it's just making that connection, and so that people can say, well, I don't know the answer to this, but I can refer you to somebody who can help you with transportation or food insecurity and that, so.
And one of the challenges, medical records are filled with everybody's bright ideas, right? And we often, by virtue of time constraints and other things, go through and check the boxes. It's got to have a meaning. So why am I asking the person if they've served or a member of their family have served? There's got to be a connection, a follow through with that. That it is linked to social determinants of health, that it is linked to healthcare benefits, that for healthcare systems it might be linked to payment from the VA for non-VA services. So there are a number of different reasons why, but the clinician in a busy clinic with 20 patients in the waiting room might not see the reason for that, and might not have the skill set to say, okay, why am I even asking this, and what do I follow up with?
And to add to that, in those clinics and things where they do ask the question, it's usually an MA or someone who asks the question, and they check the box, and then our veterans have said to us, nobody ever does anything with it, so.
So I have a question about women veterans. When we think about veterans, that's not generally what comes to mind. I think for most of us, we think about men. And I just wonder if there are any special challenges that women veterans face.
Yes. Well, they have higher rates of just about everything compared to men. And again, John's the authority on that. So I think, for female patients who served, asking the questions with great sensitivity and being aware of the possibility of military sexual trauma, they have high rates of depression. Domestic abuse, and then the other challenges that they, and they're funny stories now, and the VA really has jumped right on it, but the women who early on would go and seek VA care, they'd be in a clinic with a bunch of men, and the person would call, her name was Jones, but they'd call Mr. Jones just because they were used to caring for men. So I think just supporting them and encouraging them also to register, because there are lots of services that are available to them. Massachusetts in particular is one of the best states in terms of veterans services and supports. They've done a really, really nice job, but it's just knowing what they are and that there are women's veterans groups and there's women veterans conferences every year, and just making sure that they're aware of those and connected.
And women veterans tend to look out for other people, and their roles in families tend to support taking care of the spouse and the family, and often the woman veteran sees herself as last in line for taking care of herself. We really want to combat that denial of need, if you will, and that reticence to come into a healthcare system that is largely male. 95% of the veterans that we care for in the hospitals are men, and that can be daunting to re-enter a male-centric system of care. We're working very hard to shift that by addressing people by their proper title, by looking at what the gender of the veteran is, both for our women veterans and transgender veterans, and being sensitive to calling people how they wish. At VA Boston, we've got one of the centers of excellence, the women's division of the National Center for PTSD, which has really led the way in terms of women's health and LGBT health for the nation, and is one of the really beacons of exquisite gender-sensitive health care in the nation.
Sean, do you think, it did come up, but do you think you could just comment on suicide, particularly female veterans? Sorry, just asked him to comment on suicide and particularly female veterans and suicide.
So a couple points about suicide. We know that 20 veterans die by their own hand every day. 20 veterans. So 3 of those 20 are the guardsmen, reservists who may not have ever been federally activated and aren't eligible for VA, but are an important demographic that we want to attend to. Of the remainder 17, only 6 come to the VA. And so those other 11 are in your clinics. Another reason to ask if somebody is a veteran. Women veterans die by suicide at twice the rate of their non-veteran counterparts. And they die at increasing rates using firearms as their method of choice. Women veterans are comfortable with firearms. Many own firearms. They've been trained with firearms. And they use firearms as a suicide attempt almost twice as frequently as their non-veteran controls. And we all know that if you use a firearm for a suicide attempt, it's 95% chance that that attempt will be lethal. So people don't get a second chance. So pay attention to the women veterans in our community. They are shouldering the burden of a couple extra rocks in their rucksack in the social determinants of health that are seeking to undermine their well-being.
Yes, ma'am.
Hello, I'm Mia Chandler. I'm a pediatrician here in Massachusetts, and I have a population question. Both of my parents are baby boomers, and they are veterans. I have a sister who's still active duty, but she'll retire in about 5 years, and a brother who's a veteran. There are many more baby boomers than there are millennials, and so as I'm noticing that my parents, even though they're still young, they're getting illnesses that are related to their service. My dad was 82nd Airborne. And I hear them speaking about access to providers in the VA system. And when I'm in conversation with my sister, she's thinking about the same things because she's been deployed deployed quite a few times and has some things. I wonder what the administration is doing and how they're planning to address this large exodus of the last bit of the baby boomers from the service, and the change in how we, as not only civilian family members and caregivers, but as physicians can do, like what's happening at the administration level.
Well, one of the things that's happening nationally is a discussion around the implementation of the Mission Act. And the Mission Act went into being last Army birthday, June 14th last year, that really seeks to establish more strong partnerships between academic affiliates and the VA. There is a changing demographic. The number of veterans in this country is diminishing. Our World War II and Korean era veterans are dying, and the current rates of service are only about 1%. So the VA is thinking strategically about how to provide for the veterans where they live, and reapportion VA services appropriately. People may remember the big crisis in VA, what we refer to as the Phoenix crisis, around access to care, and that really had to do with a mismatch that veterans are, after service, tend to be settling around the military bases where they served and have established communities, and those are largely in the South. And so there's an influx of veterans in the Sun Belt. And the trends here in New England in particular are diminishing. So the VA is looking at where is the appropriate alignment of medical centers, where should they be to do the most good, and where service and figure where services need to be aligned most appropriately to meet the needs. There's a constant evolution, like any venture, any business. You want to think about where your population is and how best to reach them.
Another comment about that is, the VA has spearheaded many innovations in U.S. healthcare, and at times it's gotten a bad rap and had some challenges on access, certainly recently. But one name to look up if you have some time is a guy by the name of Ken Kaiser, who was a Navy veteran who pioneered work roughly 20 years or so ago, and he and his team sort of espoused the idea when the VA was globally, it was thought of as poor care. He came in and really revolutionized the thought process around value. So when we talk about value, quality divided by cost, or patient-reported outcomes divided by cost, and Michael Porter and efforts here at the business school and HMS, Ken Kaiser had brought that on early around focusing on patient-reported outcomes and revolutionizing healthcare from the VA outward. So take a look at that. Thanks.
So my fiance is currently a non-commissioned officer in the Marine Corps, and I've been to a lot of his pre-deployment meetings and seminars with the entire unit, and they bring in people from these organizations who kind of just give you a lecture about the healthcare that's given to veterans. They kind of just tell you oh, if you're depressed, call this number, or don't commit suicide, and it's not really effective. A lot of them feel like they can't, especially if they're currently active duty, they feel like they can't tell their higher ups I'm feeling this way, or I'm anxious, because they're worried that they either won't be listened to, or they'll get kicked off to deployment or whatever. So I feel like for current service members, there's a barrier that's internal in terms of access to care. Is there anything that the VA does or is planning on doing for current service members?
What you're talking about is one of the very important yet detrimental values that service members have, and that's one of stoicism. I think Jonathan mentioned, ranger up and suck it up and drive on. And And this military culture really relies upon all of the links in the chain to be strong. And people are reluctant to identify themselves as the potentially weak link when we know that when we attend to those needs that the unit becomes stronger. So the VA, in partnership with the DoD and in partnership with great organizations like the Home Base Program and others, really have a campaign around warrior resilience and help-seeking behavior. It's hard to really penetrate that culture and say, no, Staff Sergeant Schmuckatelli, it's really okay for you to come and get mental health care while you're on active duty. That will actually make you a better warrior. People don't buy it, and nobody wants to be identified as that guy. So there are a lot of cultural obstacles to try and overcome, and as many campaigns as we might envision to try and turn the tide, I worry, like you do, I imagine that we're not able to effectively reach the right people. But there's a huge stigma against mental illness and substance use disorders, yet those are the occupational hazards of war. And we need to do a better job of acknowledging that and encouraging people to get the help that they need and deserve.
I just want to add to that. I know a lot of the folks, being a reservist, if you go to see a civilian person, you really don't want it. You're reluctant to tell them because you don't want it in your medical record in case, it was released or whatever. I can tell you from experiences with my colleagues, but also with my students, and we were just at Home Base about 2 weeks ago, and that's an incredible organization for anyone in either active duty, I believe, as well as, reserve. They can go and they provide amazing help. They fund everything. They bring people in from across the country. Only recently have they begun to see the Vietnam veterans, which is a huge, they started out just for the GWAT, the Go War on Terror. But I have a student who went there, and it probably saved his life, saved his marriage, and he succeeded, finished school, and now is a very successful provider. So I just want to keep that as an option for your fiance and others in his unit. And I was particularly surprised when I was at Home Base 2 weeks ago that they actually have some kind of a partnership with the SEALs, where the SEALs feel comfortable. The SEALs are the Navy Special Forces folks, where they're also coming, which I think really is a beginning step to change the stigma, because the Special Forces folks and the Marines, they have a particular spirit and camaraderie that's different from some of the other services. So I found that to be very encouraging that they had that partnership.
So I want to wrap up and first and foremost thank Dr. Fraser, Hale, soon to be Dr. Florance, soon to be probably orthopedist Florance, and Dr. Bradley for everything today. It was really powerful, and I really want to thank all of you for your questions and helping share some of what we learned today with your colleagues. And I'm sure people will stick around for any questions afterwards. And a final round of applause. Thank you.
So again, thank you for attending our Equity and Social Justice lecture on Veterans Health, Caring for Those Who Served. Thank you to our panelists. We really appreciate the words that you shared with us. Thank you to the audience for being engaged and joining in this conversation. There are some resources available outside from the VA, and there's a table outside, and there's a website. Please correct me, Greater Boston Coordinated Veteran Services.org. If you have any veterans that you would like to refer to here in the Boston area who may be able to receive some benefits, please
refer them to that site. Please take a look at the back of your pamphlets. There's a list of future equity and social justice events that our office will be hosting for the rest of the academic year. And thank you for coming, and enjoy your afternoon.
Thank you so much.